Welcome back to our next case study that we're going to be doing. My name is Joel Oddie. I'm joined by paramedic Issac Piersma. Welcome, Issac.
Thank you. Glad to be here.
Isaac's going to share a case with us today in which a 60-ish year old female fell from a height and had a traumatic brain injury. But before we get started, Issac, what can you tell us about your background in EMS?
So I'm a neuromedic. I operated as an firefighter EMT for about a year or so while I was going to paramedic school at DMAC. I then got my paramedic and have been operating as such for almost a year.
So one thing I think that is significant about you on this call, being a student, EMS does not really wait for you to have experience to give you a tough call. And you experienced that as a student even before getting your certification. So tell us a little bit about the dispatch information and what you found on scene when you arrived.
So we were dispatched for a fall. Our CAD notes en route showed that the patient had fallen off a ladder and was unconscious. So we went en route emergent. On scene, we found a female. She was lying supine, had bleeding from the back of her head, and was next to a ladder that we estimate probably about 10 feet up, was unconscious, and had basically what we equated to snoring respirations.
When we talk about a significant fall, what are we referring to as a call being a significant fall?
Without taking into other factors, probably around 20 feet. But when you start to add in stuff like concrete, what they fell on, grass, whatever that may be, those add into how high it has to be for it to be significant.
Very good. Yes, I agree. That's very consistent with the PHTLS 10th edition guidelines that say significant fall for an adult greater than 20 feet, children greater than 10. However, other factors come into play, such as the surface that they land on, the age of the patient, any prior existing medical conditions, some medications that they may be taking as well. So in this case, they fell from 10 feet. Were some of those other things factors at play?
Absolutely, yeah. And just the way that she had landed, presumably it was right on the back of her head. So that ended up taking a lot of that blow right onto concrete.
So when you arrived on scene, you mentioned that she was unconscious, but we don't just say unconscious typically. We use something called a GCS or a Glasgow Coma Scale. Tell us about how you evaluated her.
So upon initial impressions, it seemed like she was at a GCS of 3. Upon further inspection, we had some incomprehensible sounds, so that then bumped her up to a GCS of 4. Still not in a range that we would like, but better than a 3 of having no sounds, nothing like that.
Sure. And the Glasgow Coma Scale, invented in, or first came about in about 1974, we tend to use it incorrectly. It was really made for trauma. We use it a lot in medical calls, and we tend to use it incorrectly, but we use it incorrectly together. But the way that this is supposed to be done is best response, so that later they know that was there a true improvement. So the common error I think I see is that when we have a confused patient and we say, oh, they're a GCS of 14. Well, could they give you a good response at any time would make them a 15, not a 14. So very direct application in trauma. However, we use it in medical calls, but maybe not exactly like it's supposed to be used. All right, so based on her fall, her initial presentation, you all are obviously very concerned about a traumatic brain injury. One thing that we sometimes associate with these closed head injuries is something called posturing. What can you tell us about posturing?
So posturing is kind of a rigidity that often results from a traumatic brain injury. So what we have decorticate, where we're flexing in like this, feet are down. And then we have decerebrate, so we're flexing outward and our feet are up. Both of those are damage within the brain that's showing us outwardly on the body.
Sure, and let's take a little closer look at that. Here I have just a simple view of the skull, and I'm going to peel back just a little bit here from the top and identify one very important structure. Here in the base of the skull we have an opening, the foramen magnum, and that is the area where the brainstem is able to exit along with the spinal cord down and to innervate the rest of the body. This illustrates the cerebrum, so different areas of the cerebral cortex. What I have highlighted here in blue is that right primary motor cortex. So this is the area of the brain that is controlling down the left side of the body. Remember, right side of the cerebrum controls the left side through the corpus callosum. But what I want to illustrate is where in the cerebrum it comes through and eventually travels here through. I have highlighted the medulla, which is part of the brainstem that sits right down there in that foramen magnum, and is where, when we get that intracranial pressure and we start to have herniation down out of the cranial vault, that we can have pressure applied. And these nerves here in yellow and red that you can see are the affected nerves that ultimately travel down and in this case innervate the left arm. One last view of this from the top. I've added that skull back in. We can see these nerves coming up again in that kind of blue-purple, the motor cortex. And as I pull down through and find that foramen magnum, we see that nerve innervation there through the medulla.
Was posturing something that this patient exhibited for you?
So we definitely had some rigidity, especially with the jaw locked up, but we did not see anything that was super obvious to us that showed posturing, at least.
Okay. One of the other concerns that we can sometimes have as we have a patient whose intracranial pressure is increasing is sudden projectile vomiting. Was that something that you had to manage with this patient?
Absolutely, yeah. So we tried to get the airway secured prior to that. We were not able to do that just because of how fast everything was progressing. But that's a huge red flag for us that we do have intracranial pressure, as all that's trying to push through the brainstem. It's causing that vomiting. So we definitely had to deal with a lot of suctioning, and it was almost too much for our suction catheter to handle.
Sure. So again, we're going to take a look here. If we have this intracranial pressure increasing and we're trying to force this brainstem out that foramen magnum, right here is the medulla oblongata, and in blue, this is where our vomiting centers are located, and if those get stimulated because of that pressure, we can very quickly and suddenly see projectile vomiting. And we associate it with that increased intracranial pressure, especially when there was no nausea noted prior to the incident at all. So we talked about some of the impact that pressure on the brainstem would have as far as vomiting and possibly posturing, but a lot of the important life functions that the body must have for survival take place right here in the brainstem as well. Some of those things being breathing, heart rate, blood pressure. And so we may start to see some alterations in some of those vital signs. Additionally, the Monroe-Kelly doctrine is the principle that states that the cranium is a static space and it's contained with brain matter, blood, and cerebrospinal fluid. And as pressure increases, it will compensate by removing some of those things out until it can no longer compensate, and then we are in a situation where we're in danger of herniation from the brainstem from the cranial cavity. I want to bring up some of the vital signs that you and your crew have documented from this case. What are some that jump off the page at you here?
So one of the biggest ones is obviously our blood pressure.
Yeah, it's very high.
Yeah, and just having that blood pressure so high is giving us that big indication of a brain injury, that we're having to have that higher pressure to push through the pressure that's building up within that brain and that brainstem.
Okay. Do you think that there would ever be a temptation for people to want to manage this blood pressure? And why is that a bad idea?
It's absolutely a temptation, and I I think it's one of the big things we like to fix things in EMS, and this is not something that we can really fix because it's managing something. It's trying to continue to perfuse that brain, and if we try and fix that, although the blood pressure will look better, it's not perfusing the brain. So having this, as awful as it seems to see those numbers, it's actually doing a good thing for the patient.
So you're saying that this is actually a compensatory measure for the intracranial pressure?
Absolutely.
Very good. Very good. What else do we see up here on some of your vitals?
So as you can see, our respirations, they're within normal limits. That was not actually her respiration. So that was us mechanically assisting it. So her respirations were quite lower than that, I'll say. Her end tidal, you can see it's a lot higher when we're ventilating with room air, and then it starts to come down into the range that we would like. And then our GCS, we ended up getting lower, and that was because we then decided to RSI her, so we had brought her down to a 3 via sedation and paralyzation. So.
Sure. Well, we're gonna move on here and look at cerebral perfusion pressure and some of the ways that we're gonna manage this patient. And when we do, I want us to remember these CO2 numbers and these ventilation rates here, because I'm gonna give you guys a good compliment. I think you guys did a great job on this.
Thank you.
Okay, so we talked about that high blood pressure as being a compensatory mechanism for increased intracranial pressure, and you referenced cerebral perfusion pressure. Tell me what cerebral perfusion pressure is.
Absolutely. So our cerebral perfusion pressure is calculated from our MAP minus our ICP. So we have our mean arterial pressure, what we have within our arteries, and then we have our ICP, basically what it's pushing against. And that ICP, as it continues to grow, that MAP has to continue to grow to overcome it.
Sure. And when we're talking about MAP, we're talking about the average pressure that's inside the arteries. A few different ways to calculate MAP. This is a very simple one that we can use in EMS, but we talk about 2 times diastolic pressure plus systolic divided by 3. Because the heart is in diastole, on average about twice as long as it's in systole, we factor that double, divide it all by 3, and we get our average arterial pressure. So what does that mean for us here? We need our mean arterial pressure to exceed the intracranial pressure so that we can get blood up into the brain. How much do we need to exceed that pressure by?
So normal, about 60 to 80 millimeters of mercury. If we have less than 50 is when we start to have that brain damage because we're not getting past that intracranial pressure.
Okay. So we won't necessarily always have the exact calculations to know these, but it is important for us to understand that when we see those blood pressures going high, that's a compensatory mechanism. We're not going to go intervening and maybe try to manage that blood pressure, give them nitro or something like that. Let it be. So if we have too high of mean arterial pressure, we've overshot it. We can have increased intracranial pressure due to our fault, and some of the symptoms of potential brainstem herniation. If we're too low, we can potentially have ischemia and nerve damage. So what are some ways that we can manage, what are some ways that we can raise mean arterial pressure if we need to?
So most often our first line treatment with that is fluids. And then if we have to go up to a pressor, we're looking at something like a dopamine or epi drip.
Okay. And if we were in a situation where we had the information that was needed that said we needed to lower mean arterial pressure, what are some ways that we could do that?
So an osmotic solution, something that's, we can get saline that's able to do that.
Hypertonic saline?
Yep. We also have the options. The easiest one is just to raise the head up to allow some of that to go back down. And then most importantly too is assisting ventilations, making sure those ventilations are good.
Very good. Yeah, I do think that we overlooked that elevating the head to lower some of that intracranial pressure is something that we certainly should be doing. And lastly, you mentioned managing ventilations. And I said earlier that I thought you guys did a great job on that. And so we're going to look at that here in just a second. But what I want to take us to next is something that I think we all probably remember from paramedic school, and that's something called Cushing's triad, and take a little look into what exactly Cushing's triad is. All right, so Cushing's triad is where we're at now with this patient, and tell me a little bit, what is Cushing's triad?
Basically, it's vital signs that we're seeing that are consistent with increased intracranial pressure.
Very good. Tell us a little bit about what vital signs we're talking about.
So the first one, that elevated systolic blood pressure, we definitely saw it with our patient. And as the increase in cranial pressure rises, so is that blood pressure on our map specifically. That bradycardia, especially as that increased cranial pressure grows, it's going to push into that brainstem and not allow for our brainstem to be able to do what it normally does. So now it's going to start vagaling down. Irregular abnormal respiration, so we were mechanically assisting ventilations, but prior to us doing that, she was definitely not breathing in a pattern that we would like. It was kind of that snoring respirations, and so kind of consistent with that Cushing's triad.
Very good. And when we say Cushing's triad, we hear tri, meaning three, and you gave us three different signs and symptoms that we may experience. Do you have to have all three?
No, with our patient, we didn't have all three. We didn't really have that bradycardia. We're kind of sitting around 100 beats per minute. And oftentimes that's just due to the fact that it hadn't progressed to that point yet. So just because we don't have all three doesn't mean we don't have an increase in cranial pressure. It often means that we're starting on that pathway and then we're eventually going to probably have all three down the road.
Very good, very good. So kind of a way that we can anticipate where we might be headed. All right, I want to look at a couple of things here on this model that will help us understand Cushing's triad. And I'm going to take away this skeleton quite a bit. And the first thing that we talked about was the increased systolic pressure. We just talked about with the cerebral perfusion pressure. The next one we talked a little bit about with the pressure on the brainstem causing some irregular respiratory pattern. It could be irregularity, it could just be slow, but some sort of respiratory compromise. And then the last thing that you mentioned was bradycardia. Now typically with high blood pressure we would expect to see a fast heart rate, and it's the opposite in this case. And why is that? Well, we're not totally in agreement. I'm going to cite a couple of different studies that think that there could be a couple different causes for this. But the ones that are commonly cited is this. Here off the brainstem, and I'll try to zoom in on this. In yellow, these are the 10th cranial nerves, or the vagus nerve. And you can see where that innervates right off the side of the brainstem. And where does it head? So again, if we have pressure from herniation on this brainstem, we could get vagal stimulation. That vagal stimulation comes down here into the cardiac plexus that you can see in this area and may slow the heart rate. The other idea that we could possibly be seeing is with those very high blood pressures that we could have receptors in the aortic arch that are saying, hey, blood pressure's way too high, go ahead and slow the heart rate down. So a couple of different ideas, could be both, but those are the two of the commonly accepted reasons why bradycardia may be present with increased intracranial pressure. Okay, so we've identified this early signs of Cushing's triad. You guys elected to manage the airway. Very well done there. One of the things that I said when I read the report I was very complimentary of was your ventilatory management. There has been some belief in the past that hyperventilating these patients that have high intracranial pressures in order to drop their CO2 was going to be beneficial. The 10th edition of PHTLS has gone away from that. I want us to take a look here at some of the guidelines. So we discussed airway management. Aim for a respiratory rate that maintains normal capnia. So we're not trying to go anywhere outside that 35 to 45. Avoid routine hyperventilation. Decreasing CO2 causes vasoconstriction. And so what the idea there is that if we're dropping that CO2, we cause vasoconstriction. We may not be able to match the cerebral perfusion pressure that we need. Avoid hypoventilation. increasing CO2 dilates blood vessels and increases ICP. So we really want to just stay with our normal ventilatory rate and shoot for that normal end tidal value. There are some instances where herniation is imminent that it may be advantageous for us to be a little bit more aggressive with our ventilation and target a little bit lower of a CO2 value. But generally speaking, we want normal ventilatory rate, normal CO2 levels. We are citing a couple of studies here that we'll put in the references as well that indicate that these patients who were hyperventilated to maintain low PCO2 values, like below 25 millimeters, showed worse neurological outcomes. So as science changes, as the evidence changes, we want to change our practice with it. And this is the latest guidance that we are being given from PHTLS. However, do always follow your local protocol as well. All right, well, let's take a look inside this patient and see what injuries actually were taking place and if those were consistent with the signs and symptoms that you all found in the field. This is a 3D rendering of the patient's skull, and from the front, we don't notice anything terribly out of the ordinary. Now you will see some things floating around here. These were just medical implements, I think, that were probably in place while the CT was being done. But here, if I transition to the back of her skull, you can see a fracture in the skull that starts here and coming around through the back and almost joins up with another fracture that starts here from completely on the other side. This is a look from the front if we peel back in, and we can look at the at that fracture from the inside of the skull. We're going to see that right in through this area, making its way around. What we want to do next is add in some blood and some tissue and really see what we have going on in here. All right, so this image is from the top looking down. And what you can start to see already is over here on the side that we believe that she landed on, you can start to see this accumulation of blood there that kind of follows the contour of the inside of the skull. It gets pretty significant right in through this area. So she's got a fair amount of bleeding. So this is what we're going to call a subdural bleed. So the dura mater is the outer meningeal layer, and this bleed is below the dura mater, but outside of the arachnoid. And the reason that we get this pattern here is the dura is adhered very tightly to the inside of the skull. But those two layers of meninges are not adhered together nearly as well, in fact, barely at all. And so if we get a bleed in that area, the easiest, the path of least resistance for that blood to flow is exactly what we're seeing here. And on CT, they'll talk about seeing that crescent shape that shows up on a CT scan. I'm going to give you another view of this. This is going to be from behind, so patient's now facing away from us. And we're going to come in, and again, we see all of this subdural bleed that's following the contour of the right side of the skull. We do happen to know, though, that that is in between the two meningeal layers. One interesting thing here as well is we also see that subcutaneous hematoma that's developing on the outside. So we possibly could have seen some sort of a goose egg in that area as well. Maybe not with the hair, or maybe it wasn't highest priority at that time. But I think this is a really illustrative picture of the extent of that subdural bleed. I do want to show you on, actually, I think we'll hop here, and again we're looking from behind. This time we have some of the brain tissue added back in, and a few things that we'll notice is you can start to see that hematoma, that subdural hematoma starting to form here along the outside. We still look somewhat midline here, don't see a lot of shift. However, one of the things that's missing is a ventricle. There should be a ventricle here. Remember, one of the compensatory measures was that as pressure decreases, it's got to get rid of something. And first it is going to be cerebrospinal fluid. So that is what's happening here, is the brain is compensating by collapsing those ventricles full of cerebrospinal fluid down the spine and trying to manage that intracranial pressure in that way. We come a little further in, we can really start to see that midline shift starting to be present. That tells us we really have a lot of swelling over in this area. We're running out of compensatory space, and eventually we're going to start seeing that pressure being put on the brainstem. Here we can see them almost both completely left of midline, and also large hematoma here. We're going to take a look at this image from the top as well. So now patient is basically lying supine with us at their head. We're going to dissect down through. Really good illustration of that midline shift. So we would expect to see this here. We have those ventricles offset to the left. Definitely that hematoma starting to show itself here on the right side. It's a great image right there.
Absolutely.
I do want to share also a CT image. Oops, it's right on top of you. I don't know if I can move that or not. Yeah, I can. So this is representative of a CT that a physician may see in the hospital, and here you can start to see. Now, in this case, the view is from the feet looking up, and so right is left and left is right, but you can still see the obvious changes here in that crescent moon shape over here, and then obviously the midline shift as well. But that is a great example of what a traditional CT scan would show in this case as well. So she has a very serious injury that is going to be a challenging case to manage. What was the ultimate outcome for this individual?
So we ended up getting an eye gel placed. With the amount of vomiting and stuff, it was very difficult to place a tube. Got her down to the hospital. At the hospital, they, after several attempts, did end up getting a tube. Placed her on life support, and she ended up becoming an organ donor. So we ended up having some good that came out of this call. But for the most part, our job was managing that airway. We didn't find anything else that was of pertinence. We didn't find any reason why she fell, like it wasn't like she was in SVT or something. So it was pretty much just managing the airway and suctioning that airway, and then doing a full trauma assessment. Very good, very good.
Well, without your efforts, it sounds like that organ donation very well may not have been possible, and some positive from this unfortunate situation may not have occurred.
Yeah.
Very good. Is there anything, if you had to go back and retreat this patient or start over knowing that this call was coming and having the opportunity to review some material, is there anything that you would have done differently on this call?
I think while it was right to backboard, I think if we could have found a way to elevate her head still by putting the backboard up, that would have been a great thing. Of course, there's the obvious, hoping that with some better tools and equipment, we could have maybe gotten that tube placed a little bit earlier, although it seemed like the iGel worked very well. But those are really the only two main things. There's a lot of factors working against us, of course. So there was a lot of stuff that we weren't able to do just because of severity of the situation and stuff. But as a whole, those would be kind of the only two main things that I can think to do different.
Well, I think that overall you guys managed this patient very well, and you should be proud of it and proud of your performance. And I thank you a lot for coming in and sharing this with us. I hope everybody watching learned something. I know I did in working with Issac to help prepare this. And as we learn new information, please share it. And as we know better, we'll do better.
Absolutely. Thank you.
All right. Thanks, Issac. I hope you enjoyed the case study that we reviewed today.